I think now are becoming more receptive and willing to entertain the idea about medicinal cannabis as as a different therapeutic agent. There was and has been a lot of stigma associated with cannabis, but now as I see, especially in Canada, since it's been legal since 2002, and since recreational has been legal now since 2018, I see a lot more seniors coming to my practice interested about, hey, you know what? I saw this commercial for it, or my friend has been using it for their arthritis.
Welcome to Be Informed, Be Well with John Malanca.
Hey everybody, John Malanca, United Patients Group, Be Informed and Be Well. And I have a special guest, not only is he a colleague, but a friend, Dr. Suraj Tandon. How are you doing, Suraj?
I'm doing great, John. Thanks for having me today. I'm very lucky and happy to be here.
Oh, always good. We do quite a bit together, so I was excited to have you on here. So Suraj is north of the border, Canadians, friends. So what's the cannabis laws up there? I know they changed. They've been ahead of us, behind us, and so it's I get a lot of calls from your fellow Canadians. Help, where do I go? And I know you shared a list of locations of dispensaries that about a year ago, and so I share that with my Canadian followers quite a bit. So thanks for that too. So you're well-rounded in the cannabis industry, and not only you're young, but you're very knowledgeable, and you had a lot of topics that you speak on a regular basis. And I wanted you to come on because we have a demographic that's, as I've shared before, 40 to 140, and and so a lot of the followers that we have are again, the 40, 50, 60s, but we do have a lot of elderly, and they come to us and say, John, help. One, how do I talk to my doctor? How do I find a doctor? Does it work for this? Does it work for that? Are the drug-to-drug interactions? And so I'm hitting different topics here. We've had one of our colleagues, Dr. Jordan Tischler, on. We spoke about elderly and anxiety, which I'm seeing in my mom and some of her friends. But with you, I wanted to talk about pain in elderly, and most commonly is associated with aging. So can you talk about the types of pain that are most commonly associated with aging for all ages as we age, but with seniors and elderly?
Yeah, absolutely. So pain, or the complaints of chronic pain, are probably the most common complaint that I receive from patients of all age groups, but certainly within the elderly age group. I'm sure we've all experienced pain. Yourself, myself. I don't think there's anyone that I've come across who's never experienced pain. Uh-huh. And so really, as we age, it's sort of like there's a lot of wear and tear on the body. And so just like a car, unfortunately, as we age, things seize up a bit. We're more prone to various types of perceptions of pain. And that can often be musculoskeletal, so issues with either the muscle tissue itself, either from a sprain, or just pulling a muscle strain. Others include down to the bone itself, and that can often be described as arthritis. So there's two types. There's rheumatoid arthritis, which often is sort of an autoimmune condition attacking the joint space, and then there are what we consider the wear and tear of the joint spaces itself. Typically in the large bearing joints such as the hips and pelvis, and that's what we call osteoarthritis. So naturally, I think the most common complaint of people experience is usually low back pain. And that's what we see in America. 50 million Americans actually suffer from chronic pain. So that's a large percentage of Americans. So it's very common. The other types of pain that we see often are gouty arthritis. So you can have people who suffer from gout itself. And then there's, the other types are diabetic neuropathy, so neuropathic pains, which can be associated with other types of disease, such as, diabetes. And there's a whole, a variety of different types of pain. So, those are probably the most common, but typically low back pain. And then you can have joint pain, particularly within the hands, wrists, elbows, and knees.
With cannabis, I'm the first to say it's not the golden pill, the golden ticket. And so take this and you're healed, or you're Superman or woman. What are some common treatments for age-related pain in non-cannabis world, but also age-related pain when incorporating cannabis that you're seeing with your patients?
Yeah. So typically, obviously, we're very excited about cannabis having a potential benefit in as an adjunct or an alternative therapy to treating pain and other types of diseases. Now, we still obviously have to look at where the strongest evidence is, where we have the strongest studies to support any type of pharmacological intervention. So, as a clinician, we look at evidence and we look at the standard of care and what's out there. And the what we sort of look at, not say the Bible, but the WHO, the World Health Organization, does have sort of a protocol on how to address complaints of acute and or chronic pain. And typically what we're supposed to follow is using two different types of modalities. One is non-pharmacological therapies, which can include CBT or cognitive behavioral therapy, mindfulness, massage therapy, physical therapy, and also injections, which can be spinal injections or various injections to the joints itself using different types of medication, spinal cord stimulators, and then also what there's been a lot of validated evidence for is acupuncture. And acupuncture is really considered one of the first line treatments for pain itself, in addition to pharmacological therapies. So it's always good to start off by thinking about non-pharmacological therapies, such as those, as I mentioned. And then, and again, the benefit is that there are no side effects really typically from those types of interventions, or if any, very minimal. The second then would be is to think of pharmacological interventions. And as I mentioned, the WHO has sort of, algorithm that we're supposed to follow, which typically recommends non-opioid medications first as a first line treatment. And those typically include our acetaminophen or Tylenol or NSAIDs, so non-steroidal anti-inflammatory drugs such as ibuprofen. Mm-hmm. And then considering other medications such as antidepressants, which can be used for off-label use to treat chronic pain. And that can be some types of medications such as duloxetine, which is a very effective pain medication, aside from elevating and improving the mood. And then others include anticonvulsants such as pregabalin or gabapentin. And those medications target pain that is caused by a neuropathic mechanism. And I'll get to a point as to how and why it's important to differentiate the pain when someone experiences it, whether it's neuropathic versus nociceptive, and we'll get to that definition. And then other what we consider, non-opioid medications would be, now medicinal cannabis, and that can be in either taking it as an ingestible in a capsule formulation, via a dropper, tinctures, inhaling it through a vaporizing device, so using the flower itself and harnessing its immediate effect by vaporization, which goes through the bloodstream quicker. And then the other, which is certainly growing, but we need further evidence, is its topical use and applying it directly to the affected joint, which we typically see in patients with either low back pain, knee pain, or pain within their fingers. The next step after non-opioid pharmacological interventions would then be to consider opioids, which again, as we see in the US and worldwide, there's a shift from using less of opioids because of its relative addictiveness, potential for lethal overdose, and so forth. But there are classifications of using either a weak opioid and then followed by a strong opioid, depending on the severity of the pain. So we always need to classify and determine how severe the pain is. Once we've determined its etiology, is to then consider first-line treatments with non-pharmacological therapies, such as what we talked about, then considering non-opioid medications like the Tylenol, aspirin, etc. Combining both of those together is really the next step. And then if all else fails and the pain is still found to be quite significant, then adding an adjunct such as a weak opioid or then a strong opioid for a finite duration of time.
With that, a lot we're 2022 now, and a lot of people at all ages are saying, I want to go to more of a healthier protocol, organic, natural protocol, and they're turning to, and I'm a big fan of acupuncture, massage, chiropractic, stretching, just movement, and that's what helps me get through the day. I am a fan of cannabinoids on the outer part of my body as well as on the inside of my body working together. And so are you seeing more patients, your patients coming in say, doc, I prefer not to, go with an opioid. I know pain's a big thing, and I'm very fortunate that I don't have pain. One of our nurses who she suffers from fibromyalgia. On the outside, she looks fantastic. So her family's like, come on, hurry up. But she said, John, I wake up every morning at 4 a.m. to get out of bed by 6 because my body is excruciating. And she learned about cannabis probably about 10 years ago. And I remember she said, my jaw dropped, like, what in the world? How come I never knew about this in nursing school? So you're talking about a lighter opioid or weaker opioid is what you said. What she's able to do is mix and match. She can take this opioid, weaker opioid, add 5 milligrams of cannabis, and this opioid, now feels like instead of 5 milligrams is a 10 milligram. So she's able to find that sweet spot. And so she does that a lot with her patients. She works with a lot of pain patients, and she's a pain advocate for patients to get not only cannabis, but also opioids with the doctor. Because I know a lot of the pain patients we work with on a regular basis, they're handcuffed.
Yeah.
Even she's handcuffed, because they'll give her 30 pills for fibromyalgia. Yeah. God forbid she has an awful day, day 26, and she has to take 2. So she runs out now on day 29. She goes in there and says, hi, doc, can I get another prescription? Or pharmacist, can I get another prescription? Oops, sorry, you're 1 day early. You're red flagged. And so it's awful what pain patients have to go through on a daily basis. And so if opioids is their answer, then give them the opioids. I mean, nothing's worse than being in pain. As you mentioned, we've all been in pain, but for the natural side, taking, hurting your organs, especially your liver, cannabis and other modalities too, don't really have those side effects. Do you share that with your patient base?
Yeah, so certainly there's a growing interest of seeking alternative therapies aside from opioids. There's been a shift again from all sorts of clinicians steering away from using opioids as well. And really, again, it's consistent with where the data is about opioid use. So one is, I think they were often handed out to patients suffering from all sorts of various, pain complaints. And there's pros and cons of its use in certain patients experiencing specific types of pain. So using opioids for less than 6 weeks duration, especially acutely, either post-operatively after they've had a surgery or they have some sort of acute need for it, is where really the evidence is. Using opioids beyond 6 weeks and longer for greater than 3 months or 1 year, really there's no substantial data to support its continued use. And that's where we now see that we maybe need to stay away from using opioids because we see the potential of lethality. In the US alone, there are annually over 40,000 Americans dying from opioid-related deaths. That's about 136 Americans dying every day from opioid-related deaths. And in Canada, we see similar numbers, but smaller statistics. Now, we recognize, yes, in short-term, use, it might be beneficial, especially in patients who are suffering from cancer pain or chronic cancer pain. That's where really the indication to use it is. In patients who have arthritis or low back pain, really, then there is no real substantial evidence to support its continued use. Again, acutely for post-operative measures, yes, opioids can be used, but again, it should always be combined in, a combination with the other types of medications, as we said, such as, the non-opioid medications, and also ensuring that we're including non-pharmacological therapies as well, such as the massage therapy, physical therapy, acupuncture, and so forth. The goal ultimately should be, if someone is on opioids, is to use the lowest effective dose to find symptom relief, and then really have a target in mind to get them off that medication altogether, because we know how addicting that substance can be. And anyone can develop addictiveness and dependency at any point. So it's not that you have to be on it for 2 days or 10 days or a year to become addicted to it. It's all genetic based on ourselves as to what, we find, can get us hooked on that sort of substance. So in terms of patients asking about alternative therapies, I do get a lot of patients who I think now are becoming more receptive and willing to entertain the idea about medicinal cannabis as, as a different therapeutic agent. There was and has been a lot of stigma associated with cannabis, but now as I see, especially in Canada, since it's been legal since 2002, and since recreational has been legal now since 2018, I see a lot more seniors coming to my practice interested about, hey, you know what? I saw this commercial for it, or my friend has been using it for their arthritis. I don't know enough about it, and they don't want to certainly go to a recreational store or dispensary, but they want to talk to a clinician. I certainly welcome that, and encourage that as well. Is to speak to your doctors, your nurse practitioners, any healthcare provider about, can cannabis can it be incorporated into my current pain regimen? And certainly I think that's the first step, is to have an open discourse about it, and then ensuring that there's no specific contraindications to its use in that one specific individual, and then sort of discussing about next steps. How can we sort of complement this as a new therapy in my existing regimen?
Well, you mentioned that more and more elderly and seniors are coming and asking this question, and I applaud that, because, I'm from the 80s generation where the stigma was still there,
Right.
And talking with my parents' generation and beyond, the stigma was really there. And so to have this conversation, it was funny, my mom's friends over the years have started calling. And I've shared this story quite a bit, where I have friends from high school that call me up and say, man, I just want to thank you. I said, why? I said, my mom's using cannabis because of you. Wait a minute, don't put it on me. They say, no. Sometimes it takes an outside family member to have this conversation. Go, well, you see, look at that. And they're like, Mom, I've been telling you this for 5 years. And so it's not, getting, a lot of the elders say, I don't want to have this conversation. My kids are probably gonna get mad at me. This is your life. And the same thing with doctors. I have a lot of elderly that we speak at retirement communities before COVID on a regular basis. And I used to ask how many people have this conversation with a doctor, and you'd have some of the room raise their hand. Others say, I'm afraid to ask, or I did ask, and my doctor said, Mrs. Jones, I'm going to act like you didn't ask me that question. Actually, that happened to my aunt. Her doctor of 30 years said that same thing. And she's like, give me a break. And one time I was speaking at a retirement community, and the lady was probably in her mid 80s. And she said, yeah, my doctor said, you better not do this, or I'm going to have to find you. You're going to have to find another doctor. I go, what'd you do? She goes, I fired my doctor. And everybody laughed. But I applaud that, because this is your health. It's not illegal in most countries. It's not illegal to ask the question about cannabis, even especially down here in the States. If you live in a legal state or not a legal state, it's still legal to ask the question. And if your doctor is not comfortable or knows nothing about cannabis or the endocannabinoid system or cannabis with pain, ask him or her if they can give a referral, because clearly nowadays, I'm certain a lot of people in your Rolodex. No, don't ask Dr. Jones, but go ask Dr. Smith.
Absolutely,
he or she knows. And so that's a question, and I want to continue with that confidence that the patients can have a relationship with their doctor and talk about what's going on here. There's so many different conditions that are coming up nowadays. Especially as we age, and even when I'm going to be 55 this year, and I never thought about this type of pain or this going on, or getting a colonoscopy. And so now at this age where things are happening, talking to my mom this morning, what are you doing? Oh, I'm going to my doctor. For what? Oh, just check up. Okay. So she's staying on top of everything. What are some conditions that you're seeing, and maybe you can share typical elderly conditions that they are finding success with cannabis, and how that is incorporating them, bringing their body into not only pain-free, but lessening the pain.
Yeah, absolutely. So I think, again, as I mentioned, that the most typical complaints that I see in elderly, aside from insomnia, anxiety, and so forth, is again pain. So now, looking at the types of pain, low back pain is often probably the most common complaint pertaining to pain itself. And then patients, again, with knee pain, typically joint pain, wrist pain. And then also what I've seen and certainly found that to be quite effective, although the evidence is kind of sparse just because we don't have enough data yet, is really in post-herpetic neuralgia. So individuals who are suffering from shingles.
Yeah.
And I've had a number of patients referred to me from, their various specialists to, try and alleviate the pain that they're having. So oftentimes, this is pain confined to the rib cage or the chest wall. And they've tried, opioid medications. They've tried the non-opioids. They've tried, in fact, steroids. And I have a number of older patients, one in particular who's 103 years of age, female, referred to me by her rheumatologist. Nice. And again, having persistent pain. She was very sort of initially apprehensive about cannabis. And this was going back in 2018, just because, again, society hasn't fully accepted it yet, but we see a slow transition and a progression towards its acceptance. But again, to her, what was most important to her was her quality of life. She could not sleep because of the continued pain. And we decided to, after having a long discussion again, that putting her on cannabis was not to get her high. And I think that's one of the fears that a lot of elderly people have, is that, if I take cannabis, I'm going to be intoxicated. I can't function. They're going to be sitting on the couch all day, or they can't continue with some of their other day-to-day activities, whether it's playing golf or driving. So I always have a discussion first, which is educating them about cannabis and the various molecules that are found within the plant. And that the goal of treatment is not to get you high, but use maybe a specific type of cannabinoid or a molecule within the cannabis plant that could provide maybe some anti-inflammatory or pain relief effect. And that's the first step, is that once you educate them, they then understand, and they sort of kind of set aside all that stigma and the misinformation, and they feel a bit more comfortable with perhaps now how this might be incorporated into their existing pain regimen with the other medications they're taking. So that's the first step I take. And I see that with this individual specifically, was to put her on a type of cannabinoid called CBD, which again is a non-psychoactive or non-psychomotor impairing substance. And the goal was to not get her high. But basically, she took that in form of an ingestible. So she took a few drops by a dropper that she placed under her tongue and swallowed. And she took that once or twice, depending on how advanced her pain was. And then we also gave her sort of, we had a discussion about considering topical use, but I wanted to just start her off with an ingestible. And to be honest, that ended up reducing her pain. Now, everyone, sometimes, I think a lot of patients will be real with you with what their expectations are. For any patient to say they have a 10 out of 10 pain and their goal is to get zero pain, I don't often see that with my patients. My patients are very realistic, where they say, hey, doc, if I could get my pain down from a 10 to a 5, that would allow me to continue to do what I love to do, which is gardening, walking, cycling, etc. And I say that's the first thing, is to have realistic expectations, setting those expectations. And if we get your pain down to zero, absolutely great. If we don't, but we get your pain down a couple of points, and now this results in improved sleep and improved quality of life, then I think that's what the main purpose of attempting to use cannabis is to try, again, improve your quality of life, reduce symptom burden. And I think that's what clinicians need to look at. Patients are not coming to us to take this to, get high and have fun, even though that might be a good positive side effect. That's not their goal. Their goal is to really improve their quality of life, whatever finite number of months, years, or days they have left. That's where we need to have a real discussion with and talk about its potential benefit.
It's funny. When you were talking about getting back to their daily routine and hobbies, I had a gentleman, he says, all I want to do is be able to roll around the ground and play with my grandkids. That's my goal. And so I thought, wow, it's a great goal to have. And he wants to be part of his family. You're talking about cannabinoids, and this, I'm glad you brought that up. Cannabis is not a one size fits all, as we do know. What works for, Mr. Jones, 85 senior male, might not work for Mr. Smith, 85 senior male. And so, you look at a few things: age, weight, current health conditions, sensitivities, physical, being, able to move? I mean, it just, on strength of the body. But I have a lot of patients say, I want the medical part, not the recreational part. And I think that's where the media has really confused a lot of people. There's about 140 different cannabinoids, THC being one, which is known for the psychoactive, CBD, which you're seeing everywhere nowadays. And so when they say medical, they're really talking about comparing that to to CBD, where recreational is is THC. I don't want people to be afraid of that, because all the cannabinoids play an important role in bringing your body back to balance. There are a lot of studies showing THC for help with analgesic pain and acute pain throughout the body. It's like, I always use this example, being in California, my brother's in the wine business, you and I can go wine tasting and take little sips, perfectly fine. We drink 3 bottles of wine, we're going to be intoxicated and not feeling too good in most cases. Same thing with THC. You can have success with 1 to 2 milligrams, 3 milligrams, depending how you are, with THC and a combination. And what is your general, a few years ago, everyone talked about 1-to-1. Someone did an article and everyone said the 1-to-1 ratio, 50% THC, 50% CBD. What are you seeing with your patients? I know it's not a one size fits all, but what is a starting kind of a dose or recommendation that you give your patients?
Yeah, so typically, again, and this is where there's obviously a difference in terms of how we practice medical cannabis management in Canada versus the US.
Yeah.
In terms of accessibility to products, testing, and government oversight, it's a bit quite stringent here. So the general consensus, and this has now sort of been evolving and changing into maybe considering different ratios of these cannabinoids, not always because of their lack of efficacy, but really because of sometimes these medications can be costly.
Yeah.
So in Canada, typically, and in the States it's a little bit different, but in Canada, typically we start patients off on sort of a high CBD product, which again, what is the purpose with starting a patient on CBD as opposed to THC or a combination of them two? Really, again, as you mentioned, THC is the one that can cause sort of the high, the intoxication, has really more of the psychomotor impairing effects, which can limit your ability to drive or work, and also has some degree of drug-drug interactions with some of the medications that people are on. We do also see that, to some extent in terms of drug-drug interactions with CBD, but the stark difference between the two is that patients who are using solely CBD and less than 1% THC on a daily routine are not getting this sort of intoxicative effects. And that's because the mechanisms are different. But CBD can provide relief in terms of, reducing inflammation, helping some instance with sleep promotion. But really, again, it's that it does have some analgesic effect. Now, compared to THC is a much stronger analgesic, meaning it's a much stronger painkiller, but it does have some of the other side effects, including, which we typically see in some degree or a percentage of patients using THC, is that typically are around above 12% and higher of THC products. They can get the sort of palpitations or the racing heart. They might get the cotton mouth or the dry mouth. And then in some select patients, but not all patients, they can get sort of the paranoia. So that's why in elderly patients, I typically use CBD just because they're already often typically on a number of other drugs.
Yeah.
And or also they have some other chronic disease, such as a history of a heart attack or a history of a stroke, or they're on certain medications. But in those individuals, because if they have a history of heart disease or heart attack or stroke, then I typically will, if anything, will start them on CBD as opposed to THC because of the cardiovascular effects that are seen with the THC itself.
Yeah.
So now the dose itself does vary. So typically what we say is try putting a patient on a low dose, which can be anywhere from what I see, starting off at even 2 milligrams and going up. There's no set dose for any individual. Typically, it's just a finding, a dose for that one individual. Is kind of like, it's like, you have a dartboard and you're trying to get a dart, on the board itself, and you're trying to find, you're trying to hit the bullseye.
Yeah.
Well, with patients, it's really trying to find that specific dose, and no two individuals, as you said, have, could benefit from the same exact dose. There's a number of variables, but typically what we do is we start low and go up in incremental effects to where we then observe some symptom relief. And if the patient finds a response at 5 milligrams, then we say we stop. There's no need to go up on higher doses. Now, typically, I find that anything above 50 milligrams of CBD, a day or per dose, typically, if we're going up way above that dose and there's no effect that we're observing in terms of symptom relief, then we say, okay, now it's time to add maybe a small amount of THC in addition to that CBD to see if we can improve your symptoms. Some individuals, if they're not, let's say they previously used cannabis, regularly, or, and they're not what we consider cannabis naive, then those individuals, we might start off with having some degree of THC right off the bat. But there's a lot of things to factor in. And I usually ask patients, are they working? Are they driving? Are they working in a safety sensitive position? Because all these things matter, especially when they're consuming cannabis.
I'm glad you said safety, because safety is a big thing for all ages using this. But, my mom's a widow. My father passed away, so she lives by herself. And I remember that, and she was never a cannabis user. Now all her girlfriends are doing it. Unfortunately, there are a lot of widows out there now. So they're all taking something different. A lot of them take, an edible because they're used to taking a pill, but I always share regarding safety is don't overdo it the first time. Don't, sometimes depending on how, I don't want to get into the best, I want to get into your best modes of intake, ingestion, after this question. But living by yourself, like you said, paranoia could come in, being unbalanced could come in, cotton mouth, heart palpitation. I mean, I've had so many stories like, I did this and I went to the dispensary and I came back. I did. Next thing I'm calling 911 thinking I'm having a heart attack. And so that's why I think education is really important. That's why I truly believe a medical doctor should be involved so they can walk you through this. I'm not a fan of sending an elderly or anyone to a dispensary for the first time. Hi, what do I got? What's wrong with you? Oh, sleep, anxiety, pain. And they come out of there with 15 different products. It doesn't need to be that way, and that's the part that this industry that frustrates me when it doesn't matter who you are, what age, you get oversold a bunch of items which you don't really need. I mean, sometimes it just takes this, and it's the domino effect of everything else falling. Sleep. When you get your sleep, oh my God, I don't feel any anxiety. I don't feel any pain. I don't feel any inflammation. So let's talk about prevention before I get into the other one. Prevention. You were talking about when we started off with arthritis and rheumatoid arthritis. And so a lot of times inflammation in the body can lead to disease, dis-ease, and also with pain. And so are you a fan of, I have my mom on, sublingual tinctures for health and wellness. Mom, take this. And it's a CBD product. And so are you still a fan of that? I know Dr. Jordan is not a fan of tinctures. Are you a fan of tinctures?
Yeah. So I would say, again, I look at in terms of any decision I make about or recommendations to a patient about incorporating cannabis, I look at really where the evidence is. And obviously, I think we're still lacking in terms of, we still certainly need higher quality, better quality evidence to look at other sort of types of delivery mechanisms, particularly, let's say, topicals, for example. So aside from tinctures, topicals is something that I have a lot of patients who have either made their own topicals at home with using, legal Health Canada approved products.
You had to throw that disclaimer in there, didn't you?
Well, no, well, the thing is, I think what the companies have determined now is that, and I'll give you an example. So
Yeah.
I have a lot of patients at times who just have pain within like one aspect of their finger or their knee or their foot, and they're a bit afraid to either ingest something because they're afraid of getting high. But if they apply it locally or topically, it's just going to provide the medicine directly there, just like Voltaren gel or those other NSAIDs that people commonly use.
Yeah.
So what I've seen is some patients make their own, and there's obviously risk with making your own, especially if you're not mixing the product, thoroughly. And so
Yeah.
sometimes you can waste a lot more product than needed, or you might not get any relief because when you do apply it, you're just not getting any of the medicine with the other sort of with the other cream, the cream base that's in there. So then they say, oh, I didn't get any benefit. So companies now in Canada specifically are developing their own topical kits. So
Good.
basically they have the ointment, and then how to combine
Wow.
the oil to it, and then they give you all the mixing materials.
Good.
But one of the, I think, as we've learned, and so have the companies, is that elderly patients, have, some struggles with, doing certain things. I've had, a number of patients who couldn't open the bottle of their cannabis oil, and that's because they had such advanced arthritis that they couldn't even open the bottle. So companies are learning, physicians are learning, practitioners are learning about, okay, how to make things easier so that they can make use of their product. With topicals, just specifically, again, I although the evidence right now is very sparse because we don't know how its distribution is throughout the body in terms of, when they apply it, how much are they actually absorbing? Does this potentially cause any drug interaction if they are on their medications? But I have seen just, in my office, a number of patients who disclose that, hey doc, hey, I've been, gonna be honest with you, I've been taking it and it works wonders, and they apply it.
Awesome.
So I do believe there is likely some benefit.
Yeah.
I just caution them because, and I can't say, oh, I recommend it because I don't know what the data is. But if they're using it and they find that it is relieving their pain, then certainly, I'm all for it. Again, making sure that they're under my supervision, I'm monitoring, their blood, and that there are no other potential harms between the other medications they're taking. Then that's the main goal. And that's why, again, encourage patients not to go and self-medicate by themselves, but to work with your healthcare provider, because ultimately we care about your well-being. And who knows, if you find relief with cannabis, we might be able to get you off the other 1, 2, 3, 5, 10 medications that you're on. And so sometimes cannabis itself can help reduce polypharmacy. So, no one wants to take more than one drug if they need to. No one wants to take any drugs. But if you're on 10 and, now you're on cannabis and you find that, hey, you know what, I don't need that opioid anymore. I don't need that ibuprofen. I don't need that Tylenol. Then that's better. We have that's a great goal in mind. And what was the second part of your question? I'm just, in case I almost forgot.
Well, safety, and I always share too, when I talk with patients that live with their spouse or widowed or live alone. Do you have any family members around? Do you have a son or a daughter? Absolutely. And if you are going to do that, make sure you have that conversation with them. And maybe for the first 2 nights, have them come over or you go there. So you're not, okay, because I know, my mom has tried it and it was funny. And I know we have. I don't want to take up your morning here, but my mom one time. I've shared this story. It's a great story, but I remember walking into her house one time and I see this big, beautiful bouquet of flowers on her dining room. I'm like, who the hell is sending you flowers, Mom? So she said, oh, it was her girlfriend. And I said, what'd she do? She goes, you spoke to her and she's sleeping better and she's doing this. And she sent me flowers, say, thank you for introducing her to. So I thought, how cool is that? You're seeing these success stories. My mom has an arthritic finger. I said, try this top. She does it. Like you were saying in one area. She's like, oh my God, I couldn't do this before. Now I can do this. And so it's neat to see that. My mom too, Corinne, who you didn't get to meet, my wife who passed away from cancer. I mean, I'd talk to my mom, good morning, good afternoon, good night. And this one evening we were saying goodnight to her and my mom says, can I ask you a question? I'm thinking, okay, what? And she says, I've been all my friends are taking some stuff, and I was taking a little gummy, I think it was, or popcorn. I forget what it was then. This was probably about 7, 8 years ago. And she says, "Does it help with sleep as well as pain?" She goes, she's a tennis player, old tennis player, I haven't played for years, but she goes, "I don't have pain."
Yeah.
And I was silent to hear my mom. I mean, if it wasn't for my dad, I think my mom would have been a nun. So to hear that, I was silent. And I remember Corinne hits me. She's like, be supportive, be supportive. And I said, yeah. She's like, wow, it's amazing that it does that to the body. She goes, I think if I knew about this when your father passed, I would have, helped with sleep and stuff like that. And so it's nice to see, hearing their stories, not only because it's my mom, but even the retirement communities. My husband passed away, and I was in my room just sad and depressed, and my kids brought this over, and next thing you know, I'm down having dinner with my fellow they call them inmates is what they call them, retiring, my fellow inmates. But it's neat to see that the success of this plan. It's not for everybody, but it's neat to see that there are some, not giving patients or anybody false hope, but giving them hope. You spoke about drug to drug interactions, and can you talk about some drug to drug interactions and what to look out for, and what maybe some medications to stay away from? Or, because I'm a fan, when you're battling something as severe as cancer or something like that, having a whole arsenal, and let's do this, let's do that, on different modalities of chiropractic, acupuncture, maybe conventional if you're going to do chemo radiation, but also incorporating cannabis in there to help as much as it can. But there are some drug to drug interactions. Are there things that you would say, hey, time out, let's do, I prefer you not doing this, or yes, it is okay to combine?
Yeah. Okay. So, and I'll comment on two things. One is, remind me, the first thing I'll talk about the drug-drug interaction. The second is I do want to get back afterwards about the reducing, or, the harms with cannabis use, particularly in mitigating the potential harms. And you touched on some of that already about, and I think, John, you must be a doctor, because the fact that you said that you have, having someone there, for the first 2 nights, if someone's starting cannabis, especially in older patients, that's what I typically recommend for patients, is that if they have a family member for the first couple of nights, it's good to have someone there, in the house, just to be there as, as a backup. Again, we know that elderly individuals, as we age, we have, some decline in our gait stability, our muscle strength. We're at a higher risk of falls and imbalances. Our vision is a bit weaker. We get a bit more disoriented, especially when we get up out of the bed. So, and now if you combine cannabis, then, there isn't a significant harm, but it's always good to be cautious. And again, that's why it's important with elderlies. I often will recommend them starting the medication at bedtime, because, they're typically at bed and they're going to sleep for, 5-6 hours if they're lucky. And so you're allowing the medication to take effect. Whereas during the daytime, it might be a bit more cumbersome. So I always advise individuals to take the medication at night, have someone around for the first couple of days, especially if they need assistance with going to the bathroom. So toileting is also a concern. And a lot of individuals, unfortunately, have to go to the bathroom at night. So as you mentioned, I think that's always good, is to have someone there at night for the first couple of days. And then basically we get used to it. In terms of drug-drug interaction, so I would say the only drug that I would ever consider sort of an absolute contraindication, and again, there is some debate about this, is really in terms of immunotherapy drugs. So these are specific drugs that are used to treat specific types of cancer. Now, really the concern about the drug-drug interaction is usually in younger individuals who might be on this medication if there is an intent to cure their cancer. And what we know with one of these drugs, or the class of immunotherapy, so not the traditional anti-cancer drugs such as, the platinum-based chemotherapy agents, there isn't any drug-drug interaction with those. But the ones that we are sort of right now on the radar, and there's some evidence that shows that there is a potential drug-drug interaction and can reduce the benefit of the cancer drug, is in immunotherapy agents.
Gotcha. Good to know.
So in those specific patients who are on that drug, I make sure I have a a full discussion, not only with the patient, but their oncologist, whoever is prescribing them that medication, that they're aware that they've come or they have been using cannabis or they want to use cannabis. Then I say that, and I've had a number of oncologists here in Canada, especially, who were not aware that of the potential drug-drug interaction, despite recommending cannabis to their patients. So
Yeah.
they take a step back and I say, listen, it's not to say it's absolutely you can't ever use cannabis, but I say, let's first look at what the goal is. So right now, if you have a cancer and the goal is to treat and cure your cancer, then I'd say let's hold off on the cannabis for the time being until you complete your cycle of the medication. And then we can maybe consider incorporating it. That's really the approach I take with patients whose intent is to cure their cancer. Now, there are some patients, as a palliative care physician, who I know who have metastatic cancer or stage 4 cancer, and they are sometimes still prescribed these immunotherapy drugs. Then the discussion is, what is the goal of including cannabis, and what is the goal of the immunotherapy drug? Is it to reduce symptom burden or not? And typically in those patients with advanced metastatic cancer, the goal is not to cure their cancer at this point. And we know that the immunotherapy drug is not going to cure their cancer, but it might have a role in reducing the pain that they have, or the spread of disease that might affect their breathing, or so forth. That's when I have a discussion with the patient and the oncologist and say, okay, there may be a potential drug-drug interaction where it might reduce the benefit of that cancer drug. But if the goal is to try and alleviate your pain or improve your sleep, then this might be a safe, acceptable reason to incorporate cannabis use.
Okay.
That's really the only drug that I typically will avoid. And or sometimes with patients who had a recent heart attack, let's say within the last 6 months, and they are what we call on a antiplatelet agent, such as like Plavix. So when you have a heart attack, sometimes these patients are prescribed one of these antiplatelet drugs to reduce the risk of them having a subsequent heart attack. There is some evidence to suggest that shows that the interaction of cannabinoids with antiplatelets can reduce also the efficacy as well. So again, I have a heart-to-heart discussion. I say, let's hold off for let's hold off for another 6 months, or wait beyond 6 months before we consider cannabis, because there are, again, many traditional drugs, other drugs that we can utilize. But and then we can have a rediscussion about maybe incorporating cannabis. The other ones typically is Coumadin or warfarin, which a lot of patients are on for blood clots or different heart valves.
Yeah, because those are the ones I've always heard is blood thinners, as well as heart medicine. You covered both of these, and I did not know about the immunotherapy for cancer patients. I heard with chemoradiation, you can incorporate cannabis and it not zeroing out, negating the benefit, I guess, if you want to say benefits of other conventional cases. And I would never tell anybody not to do, I've seen it work, I've seen it not work. I've seen cannabis work, I've seen cannabis not work. And so I would never tell anybody not to do it. And that's the part where I said, it's, say chemo pain. I think cannabis is very beneficial for not only for pain relief, appetite stimulation, mood, sleep, nausea, all the above. And so those are the parts where I think, one, having discussion with your doctor.
Absolutely.
And it's, people always come to us and say, does it work for this? Does it work for that? And I don't want to say it's like duct tape with 1,000,001 uses, but when you really get down to it, it's amazing all the benefits this plant has to offer. And it doesn't work for everybody. Like I said, it didn't, how we got started in United Patients Group with my father-in-law with stage 4 lung cancer metastasized to his brain. We didn't know the benefits. They gave us 2 weeks. All we wanted was appetite stimulation. Well, his eating got him healthier, and the cannabinoids not only got him healthier, but also we're attacking the cancer cells. So coming out of the gate, we hit a grand slam with my father-in-law. Let's fast forward, 8 years later, or fast forward 8 years, which is now going to be 5 years. Shoot. My wife, who had the most, perfect healthy lifestyle, diagnosed with pancreatic cancer. And, she passed. And so we tried everything from stem cells to, work with a lot of functional and integrative medicine, even cannabis. The pain, I remember she had tears in her eyes, like, how come this is not helping my pain, John? And so it just killed me that everything that we've learned, and it just shows you that it's not a one size fits all. Because most pancreatic cancer patients, unfortunately, you've been diagnosed and 48 hours later or 2 weeks later, I had 4 beautiful months with Corinne, and she wasn't really into a lot of pain until towards the end. And so I don't know. And that's why I think more studies need to happen for all patients and all ailments. Let me actually have one question here too.
Absolutely.
This happens all the time. John, is cannabis covered by insurance? And it's not covered by insurance yet down here. What about up in Canada?
Yeah, so great question. I'm hoping, especially for the States, just like in Canada. So I hope that as we see, as the federal government, as the insurers realize that this is probably a better alternative than opioids, it's safer, it's going to cause less harm, less direct cost to the American healthcare system, that they will consider subsidizing the cost for their patients. And I hope that they do. In Canada, we're a little bit ahead. It's not covered by the government per se. There is some nominal coverage by third-party insurers under what we call a health spending account. Cool. And there are a number of insurance companies that cover a couple $100. So it doesn't cover the overall cost, but it's a starting point, is my point. Yeah. I'm hoping that also that the Canadian government with time will recognize that this is likely a much more cost affordable medication than the other prescription medications that Health Canada does have on the formulary, and that they allow for coverage for patients. So again, in Canada, we're slightly ahead with some insurance companies covering the cost of this. But again, if patients are taking this regularly, then there certainly is a bit of a cost to it. But I think in the States, there will be that same follow-up. And I think just like, Canada and the US, we're neighbors. So we often look at each other as to what we're doing. And I think, the US, and hopefully they will make, some of the same recommendations.
Hopefully, to add on the insurance thing, it's funny. Years ago, I was interviewing, we did a whole thing on veterinary and pets and families. And this family said, oh no, on our pet insurance, we write cannabis and they reimburse us. I don't know what the cost was. And the funny thing is, it's illegal for vets to recommend cannabis to their patients, their dogs, but pet insurance will cover it. Whereas humans, it's in most cases in states, it's legal to recommend medical cannabis at the state level to your patients, humans, but insurance won't cover it. And I hope everyone will get on board somewhere. I mean, it's amazing. Some states down here, here are qualified conditions, while other states over here, sorry, pain's not a qualified condition. Pennsylvania just made pain a qualified condition the last 2 years ago. Cancer in some states, nope, you don't have cancer, but we'll allow you to have pain as a qualified condition, or epilepsy, or et cetera, et cetera. So, it's unfortunate. All states have different laws down here. And hopefully they'll have an idea about across the board, not only with qualified conditions, but safety and products. So to our listeners, ask questions. Don't be afraid to ask questions about the safety of your product. Make sure all your products are tested. And when I say tested, it's not up to you, it's up to the dispensary or whoever you're purchasing from to have an up-to-date, lab report, certificate of analysis, also known as a COA. And if you have questions or they can't submit that to you, go to another company. There are so many companies out there. And if you still have questions, you're always welcome to reach out to me here at United Patients Group, as well as Dr. Tandon up there. And I'll put all your information up there, Suraj, for that. I can go on and on and on, but I maybe this will be a part 2.
Absolutely.
But I appreciate you as a incredible doctor, but human being, and what you're doing for this industry, and the work that Suraj and I are doing together with Dr. Tischler is pretty amazing on what we've accomplished so far, and still doing it. Do you have any closing words for?
Yeah, absolutely. So John, first I want to just commend you on having this platform for all your listeners. I think it's an excellent platform for the listeners who are out there to get succinct, accurate, evidence-based information. And I think that's what's truly important.
Yeah.
And then to have John and his organization to really support patients, to be a strong advocate on your behalf, I think is absolutely vital. And you're doing an excellent job with connecting with people, leaders within the industry who can comment on this. And I think that's what's really most important for patients, is to get, credible information, to remove the misinformation, the disinformation, and to speak to experts in the field. And my last vital point that I would give to all the listeners out there is to, encourage you to have open discussion with not just your doctors or your nurse practitioners, but your family members. I think we're at a stage where we're evolving. There's a lot of destigmatization now, which is a good thing. We're looking at the potential benefits of cannabis. And cannabis, again, I'll remind you, is not a new substance. It's been around for thousands of years, used all across the globe, again, all for medical purposes. So I think that's the first thing, is looking at the history about it, and that will remove a lot of the stigma that, and the biases that we might have about it. But have an open discourse with your doctor, your nurse practitioner about, whatever complaint you have, and maybe if there's some benefit. It's always better to speak to a healthcare provider, because our goal, again, is to improve your quality of life, reduce your symptom and disease burden. And if we can find a substance that is maybe better, newer, has less side effects, and can meet all of those goals for you, then we're all in. That's what we want. And you're doing this under the supervision and the care of a provider who can ensure that there aren't any major harms, there aren't any drug interactions. And that's what medicine is. That's what the beauty about providing healthcare is that we want to work with patients. We want patients to sometimes teach us as well. So, teach your providers. If you have a doctor who doesn't know about it, then this might be a way to educate them as well, right? Doctors don't know everything. Yeah. And now with the advent of technology and the internet, you can really encourage us to learn more. And that's what medicine is. We're constantly learning. We want to help our patients. And that's really the main thing I can encourage all of you guys to do, is not be afraid. You can't get in trouble for having a discussion about it. And again, it's your body and your life. So why not look at alternative ways to really improve that?
Beautiful. Well said. I want to add to that too. I'm a fan of journaling. Write down what you're experiencing, what your pain level is, what you've eaten, how you slept, and then what if it's chiropractic, acupuncture, or even a pharmaceutical and or cannabis. Write it down to see what how you're improving day after day, week after week, month after month, et cetera. And another thing, I always like doing this as well. So a lot of times, Suraj, a lot of patients, I'll refer them away from cannabis. Try this first. And one thing that I'm a big fan of, and an old colleague shared this with me years ago, what he does with his patients is sit there. It doesn't matter if it's pain, anxiety, depression, whatever, but take a deep breath and take a full body check. How do I feel? Am I in pain? Am I at a level of 1 to 10? Am I at 11? And then incorporate cannabis or whatever you're doing, and then go back and do another full body scan. Take that breath, inhale, let it out, and go, okay, is my pain now a 10, or is it a 2, or a 5, or a 3? And again, write that down, and you'll know, and that kind of helps you guide, engage what works best for you. We're all made differently, but we all have that sweet spot that works perfect for us as well. So, Suraj, my friend, always great seeing you, and look forward to doing many more things together in this industry and beyond. But I appreciate you and all you do, and hope our audience enjoys you as much as I have. So, thanks everyone, and thanks Suraj, and again, John Malanca, United Patients Group. Be informed and be well, and we'll see you soon. And how do they reach you again? I'll put your information below, but
absolutely.
I'll put the information there for everyone. So anyway, have a great day, everyone. We'll see you later, Suraj. Take care. Bye-bye.
Thank you for listening to Be Informed, Be Well with John Malanca. Be Informed, Be Well is brought to you by United Patients Group. Come and visit us at unitedpatientsgroup.com. And thanks for listening.